much, Heather. I'm going to just take the mask off. Is that okay to talk? Thanks, everyone. It's a pleasure to be here tonight. Spoiler alert, the upper esophageal sphincter is our foe, which I hope to convince you of tonight. I'm going to try to, these slides are all in your handout, so please don't try to keep pace with me because we're going to whip through this like light speed. But I wanted to talk a little bit about swallowing, just about the phases and what the upper esophageal sphincter does in this, the roles of the sphincters and pathology and treatment. As you all know here, swallowing mechanism is complicated. There are cortical inputs. There is important pathways that lead from the cortex for voluntary swallowing to the midbrain, which houses the central pattern generator for reflexive swallowing. Injuries to the central nervous system, whether it be through stroke or neoplasia or trauma, can vastly upset the swallowing mechanism. I'm not going to belabor the whole spectrum of pathology tonight around this, but just to say that a variety of lesions can affect our swallowing mechanism all the way from the cortex of the brain.
I'm just going to fix because somehow your slide stopped sharing, so I'm just going to fix that.
By all means. All the way down to the neuromuscular junction. And we'll talk briefly a little bit about applications for therapy there as well. Yeah, that's too bad. We'll see. We'll get back on track here in just a sec. Okay. So as I was saying, the upper esophageal sphincter is our foe. Where does the esophageal sphincter come into play? As you all know here, we have an oral phase, which is pretty much voluntary. But once the oral phase transitions into the pharyngeal phase, we start to involve the function of the upper esophageal sphincter. And the upper esophageal sphincter, as you know, relaxes during bolus transition into the esophagus and then contracts and closes to prevent reflux of contents back up into the upper aerodigestive tract. This is a very coordinated series of reflexes and events allowing passage of material into the stomach. So what exactly are the roles of the sphincters? Quite simply, they're to prevent air from entering into the GI tract and to prevent reflux from happening from the GI tract back up into the aerodigestive tract. And we have two esophageal sphincters, as you know. Tonight's discussion is on the upper esophageal sphincter up here in our neck. The literature around the taxonomy of the sphincter is a little confusing. Some people consider the cricopharyngeus to be the upper esophageal sphincter, but actually the cervical esophagus as well as the inferior constrictor are part of that. Interestingly, this is a zone that spans about 3 to 4 centimeters involving all of these structures, even though the cricopharyngeus is 1 centimeter wide. We're going to get into a little bit about why that kind of makes clinical sense, because we tend to target the cricopharyngeus selectively, even though it's not the sole contributor to the upper esophageal sphincter. The muscles are under the majority of the majority control of the 10th nerve. Interesting things happen when we swallow. If we have air entering into the esophagus, the sphincter relaxes and passes past the sphincter, but a liquid entering into the esophagus will cause the sphincter to tighten up. So why is this actually important tonight? Because I'm sure, as many of you know, many patients with dysphagia, whether it's due to the upper esophageal sphincter or not, often complain of problems up here in the neck. And they will tell you that I have problems up here. This is where my problem is, even when it may not be where the problem actually is. And you know, when we look at the literature a little bit, some of the older terminology refers to things like block dysphagia. So if you're swallowing something and it's getting stuck, we sometimes think of it that way. So I'm going to just show you some rudimentary diagrams to help us kind of in our concepts here. Basically, the cricopharyngeus is at rest, it's constricted, it doesn't allow things to pass, but then when we swallow, the muscle relaxes and allows the bolus to pass. Failure to relax causes things to get stuck. But there are other things that cause problems with the upper esophageal sphincter. You can have primary muscle dysfunction, such as we see in inclusion body myositis, which we'll talk about, which is a disease primarily of the muscle and other muscles of the body. We may have GERD happening, which causes the sphincter to reflexively contract. So even though the problem isn't with the sphincter directly, it's indirectly related to pathology in the esophagus. We see direct injury commonly from chemoirradiation, and we'll talk a little bit more about that. This particular injury can be fairly horrendous for people because it can result in total obstruction at this level and no ability to pass food or liquid at all. and requires us to engage in some pretty complex reconstruction. When we look at some of the things that Dr. Clark's going to talk about, achalasia, the problem primarily is with the lower esophageal sphincter, but many patients will say, but I'm feeling it up here. And why am I feeling it up here? Because they're not able to pass things through the lower esophageal sphincter. The same with conditions like dysmotility, where there's poor contraction or disordered contraction, or when there's bona fide obstruction, such as tumors and cancers of the lower esophageal sphincter. We tend to think of the development of problems in this area as a spectrum, and there's a naturally occurring dehiscence or weak spot between the inferior constrictor and the cricopharyngeus called Killian's dehiscence. And this is an area where we tend to see the development of Zenker's diverticulum. And conceptually, we tend to think that high pressure at this level around the cricopharyngeus may predispose the development of a diverticula, which basically pulsions through that natural dehiscence. And if you kind of look at barium swallows in the natural spectrum of this, this is your typical cricopharyngeal bar, which we tend to think of on a barium swallow when we're seeing isolated cricopharyngeal hypertonicity or spasm. But as we think that as time goes by, there's kind of a slow emergence of a diverticulum that slowly enlarges until we see kind of the classic Zenker's, as you see here. Inclusion body myositis is something that we tend to see not infrequently here at Stanford. This affects older patients. Many patients are affected by an inability to stand. They may fall. They may develop wasting in the arms and the legs. And one of the things that happens is they can develop profound dysphagia from involvement of the cricopharyngeus muscle, which can actually be lethal for patients in the development of pneumonia. When we actually look at this disorder, what is interesting is the development of what are called inclusion bodies in the muscle. And so the muscle fibers themselves deteriorate and degenerate and are no longer able to kind of relax. And this is a situation where we'll want to maybe deal with that muscle. Just real quick, is we still projecting okay? I heard that little beep go off. Perfect, wonderful, fantastic. So let's talk about treatment as we're moving along here. So treatments break down into several buckets. Treat the underlying disorder. If it's GERD, treat the GERD. We can teach patients to adapt to their swallowing problems through things like swallowing therapy or dietary modification. And then we can get into the surgical side of things, which involve things like bypassing the problem entirely, which is sometimes necessary with tube feeding. We can dilate the sphincter. We can denervate the sphincter with Botox. We can cut the sphincter, called a myotomy, and in cases we looked at with the radiation problems, sometimes more complicated, reconstruction is important. So how well does dilation of the upper esophageal sphincter work? Well, it kind of depends. What one can say is that it's a fairly minimally invasive thing to do, fairly low tech, but unfortunately dilation has a tendency to decline over time, such that the efficacy may wane by 50% at 6 months. So in terms of a long-term solution, it may not be the best. Bypass, you can certainly do that. We're talking about quality of life issues when we deprive the patient of the ability to swallow by mouth, but it is a fairly minimally invasive thing to do, and it is reversible. And as we all know, not all patients need to be NPO. They can sometimes combine modalities and have some sustained quality of life. Chemodenervation, we principally refer to the use of Botox injected into the upper esophageal sphincter. This relaxes the muscle. Again, it's a fairly minimally invasive, low-risk thing to do. The duration of the effect is like dilation, somewhat limited, and may vary from study to study from 2 to 14 months, depending on how much Botox you put in there. So if we're going for a longer-term solution, we generally tend to think of myotomy, so surgically cutting the muscle. When you have a diverticulum that occurs in concert with the muscle in spasm, we may want to do a diverticulectomy, take the sac out concurrently in order to treat the problem. But as you can imagine, these more invasive things now carry greater risk. We're talking about bleeding, infections, fistulas, recurrent laryngeal nerve injury, and in the worst case scenario, mediastinitis, which is potentially a life-threatening condition. However, sometimes the juice is worth the squeeze when you look at the long-term efficacy of cure rates that approximate 80% in some studies. This is diagrammatically what we do surgically. Your typical Zenker's diverticulum, it does look this neat and clean when you're operating. It always looks like this, so real easy to do. This is what the diverticulum looks like when you've dissected away all of the muscle and done the myotomy. We remove the sac, and then we do a completion myotomy. Most authors indicate that we probably need to cut not only the cricopharyngeus, but a little bit of the cervical esophagus and a little bit of the inferior constrictor to really reach that entire sphincter that we were talking about earlier. But what happens if we look at these things endoscopically? There are other things that you can do other than open the neck. You can also operate endoscopically. This is what your typical appearance looks like with the esophageal lumen superiorly and the Zenker's diverticulum inferiorly. In the past, we would place a special scope and use a stapler to just divide that common wall and make it easier for things to kind of bypass and slide past that area of obstruction. One of the things that Dr. Sung and I have kind of realized here at Stanford is that, well, if you can actually cut the muscle, it's actually possible to resect the muscle selectively, including the sac. So diagrammatically, when we place these scopes in, we may actually expose the cricopharyngeus muscle in its entirety, expose it, resect it, and then take the sac out concurrently endoscopically as well, and then close the whole thing up. And this is something we found rather nice for patients, especially for those that recur after stapling and that don't really want an open procedure but prefer to stick with an endoscopic approach. When we talk about things like radiation injury, very tough to rehabilitate this. The radiation causes a concurrent mucositis and fibrosis of the muscle. If the entire lumen is completely obstructed, we sometimes have to reconstitute a lumen. We can no longer use dilational procedures. And as we looked at earlier, this is what that problem looks like. This is, I just wanted to illustrate how complicated the problem can get. We sometimes need to place complicated stents in the area to reconstitute the lumen and get a new lumen to heal. We sometimes need to open up the area of the sphincter externally, exposing the muscles, removing the scar, and rotating tissue from another part of the body, in this case, skin from the skin and sternocleidomastoid muscle, to reconstitute a lining, and which is then stented to kind of maintain this lumen open. And these types of staged procedures can obviously take some time and take a lot of effort and invasivity to do that. If patients have total stenosis of this area after chemoradiation, we may be able to do what's called a rendezvous procedure. We do this with John not infrequently, where he'll come from below at a G-tube site and we'll come from above, meet in the middle, open up this lumen and stent it. It's great when that works, but if it doesn't work, we have this type of stage stenting procedure that we can fall back on. So it can be quite complicated. As I said, everything is in your handout. I originally planned to talk for 60 minutes. Then Heather told me I only had 15 minutes, so I am now done. As you know now, the UES dysfunction is a spectrum. There's a number of pathologies that affect this. There are a number of treatments that are open to us. This is a team effort. We all must work together if we're gonna put the upper esophageal sphincter in its place where it belongs. Right, Jennifer? You're with me, right? I knew you would be. With that, thanks so much for your attention. It's been great to talk to you, and look forward to taking any questions. So thank you.